Okay, we are here now on the last portion of the chest and the lung examination. We've gotten to the point where we're going to be doing the auscultation. So our patient here, we're going to go ahead and have him sit facing opposite ways so we have better access to his posterior portion of his chest and his lungs. We're going to go ahead and ask him to bend his head forward just like we did previously. Can you sit up straight a little bit? Just fold your arms forward and then kind of bend a little bit forward. Okay. So when we do this, now we got a better view of the lungs or more surface area where we put our stethoscope so we can take a look at the lungs by moving the scapula sideways. So we're going to go ahead and auscultate in a pattern where we start here at the apex of the lungs, going from left, asking him to breathe deeply and gently, and out. Moving to the right, in, and out. Moving on down, in, and out. Again, in, and out. In, and out, in, and out, in, and out, in, and out, and the last portion will be in, and out, in, and out. Okay, so that is the way we auscultate the posterior portion, always going from left to right, right to left, left to right, right to left, left to right. Then we're going to go ahead and ask him to sit sideways with his arms up so that we have, so we're able to auscultate the lateral portion of the lungs. And we're going to go ahead and start here and ask him to go ahead and breathe in and out, in and out, in and out, and one last time, in and out, always going from the apex to the lung base. Then we're going to come around the other way, and again with his arms up straight, we're going to go ahead and also auscultate. Again, one, and out, in, and out, in, and out, and once again, in, and out. Now also, we're going to auscultate anteriorly, and we're going to have him face us. And we're going to go ahead and start off by auscultating the sides of the trachea. So we're going to go ahead and ask him to breathe in and out. Breathe in and out. Now here we're listening to bronchial sounds. This is actually the only place that you'll hear these high-pitched sounds. And then when we move down, we're going to go ahead and start hearing for the bronchovesicular sounds. Go ahead and breathe in and out. In and out, in and out, and in and out. You may want to ask your patient to brush his teeth before he starts his assessment. And here we're listening to bronchovesicular sounds, and this is lower in the portion of the bronchus where the two bifurcate into the two main bronchus. And that's where you hear the more moderate pitch sounds, lower pitch definitely than the ones in the trachea. And then as you move down, you're going to hear vesicular sounds, which are more of a low pitch. So go ahead and in, out, in, and out. Okay. So that's how you auscultate the different portions of the lungs. And then after you go ahead and do that, you want to go ahead and go ahead and start to assess for any type of abnormal breath sounds while you're doing this, as there can be different types of forms of atelectasis or consolidation that may appear, and you need to know what those different things sound like. For example, if I was to hear on auscultation maybe a crackling sound on inspiration alone, you need to know that that this sound, this what they call crackles, is a sound that you hear, and it's kind of like the word. You hear crackling, but it's very discontinuous. It is of a higher pitch, but disregard that because sometimes it could be at a lower pitch, but primarily heard on inspiration. Another thing, the rhonchi. Rhonchi is also a common finding in some patients that have pulmonary issues, and with this one you would hear it on expiration alone, and this is more of a lower pitch sound, and it's got the rumbling tone to it, and unlike the crackles that are discontinuous, the rhonchi is actually a continuous rumbling tone. And then you have sometimes wheezing in the lungs. And whenever you have wheezing, that is a very, very high-pitched sound, and it's almost like a whistle that you hear. And you could either hear it on inspiration or expiration, sometimes even in both. And then what you have is a friction rub. When you hear a friction rub, it's inflammation of those pleural cavities, and thus you hear like a dry rub, even grating, sometimes even crackling, but you hear that on inspiration and expiration as those lungs bring in air and then bring it out, and as those two layers of the lungs kind of rub together, that would be your friction rub. And then you have what they call a mediastinal crunch. When you have a mediastinal crunch, mediastinal referring to the portion of the thoracic cavity where the heart lies, in between the lungs. So mediastinal crunch is whenever you hear a loud, crackling, crunching, gurgling sound, and it's normally repeated with each heartbeat. So those are all things that if you find them, you definitely know you're dealing with something in the lungs, either air or either fluid, atelectasis, leaking, pulmonary edema in a lot of cases where patients have cardiac failure, renal failure. So you definitely want to inspect these, because you'll see that whenever you have these types of findings, most of the time you'll be able to correlate or associate that with what you're seeing on your vital signs when your saturations are falling or the such. So very, very important to be able to know how to assess and what to assess for, and what it means when you find certain things, or what it could lead to. Another thing is vocal resonance. Now, vocal resonance is another thing that you can auscultate for. It's a lot like the tactile fremitus. It's pretty much identifying the same things. If you have a lot of consolidation and you have the person repeat a certain number of words, such as like we did with 99 in tactile fremitus, the resonance will be a lot higher pitched. Even when a patient even whispers something, you'll be able to hear it with a lot of clarity and at a high intensity. And then just the opposite in patients that have something like emphysema, where they have a loss of tissue in their lungs, that resonance will just be the opposite. You will not hear that, or you'll hear less of it with a less intensity. So there's different terms that refer to those different types of things. And first of all, the one that I told you first would be the one that upon auscultation is just a very much louder vocal resonance, higher pitch, and that would be your bronchophony. When you have broncha referring to the bronchus, and bronchophony referring to just the louder resonance or pitch of sound whenever a person speaks a word or a number. So when you do this, just like we had done with tactile fremitus, you go ahead and put your stethoscope over in wherever you have the main bronchus, go ahead and have them repeat the word, such as 99.
99.
Go ahead again.
99.
And again.
99.
Okay.
99.
Again.
99.
Uh-huh.
99.
Okay, and what you're hearing for is that symmetrically that the sounds are just about the same on both sides, and that they don't, kind of strike you as way too loud and very, very high of a pitch. And you do that posteriorly as well, just like we had done with tactile fremitus. You could do it on the lateral sides of the lungs as well, just to hear the difference, if you have any, in the resonance of those spoken words. And when we were talking about the whisper, that even a slight whisper you could hear very well in cases where you have consolidation. That's what you call a whispered pectoriloquy. Now, such as, when he speaks the word, for example, 99, you would go ahead and again auscultate and tell him to go ahead and whisper the word 99.
99.
No, whisper it. Okay, so again, we're trying to hear to see if that whisper is extremely clear to us, and if that's the case, then we also again know that we most likely have some consolidation there. Now, egophony is just another word where when we're hearing these sounds, not only are they clear and we can hear them very well, but also they have like a nasal quality, more of a higher pitched with that nasal quality in the resonance of that. Other things, if the patient presents with any type of cough, you always want to go ahead and assess the cough in itself and see if it's more of a dry, hacking cough, or if this is, if you can tell that it's very moist, and possibly he has a buildup of sputum back there. You want to ask the patient when it first started, and you want to know while he's sitting there with you, how many times is he coughing? I mean, is he coughing every second, or is it just once every 15 to 20 minutes? I mean, you really want to know, how often it's occurring. And then you want to see the pitch. Is it a very, very loud pitch of cough, or is it kind of a lower pitch of cough? That would be able to tell you sometimes how low the problem is, as far as if it's in the upper respiratory, or if it's down lower. And you want to see the quality of the cough as well. So these are all also things that, we assess on a day-to-day basis as nurses, but we've got to kind of remind ourselves exactly what we're looking for and why we're looking for those exact things. Usually our respiratory therapists that we have in the hospital are the ones that normally assess things like peak expiratory flow, and but however, it's nice to be able to review that ourselves to know what it is that we actually use that for. So in actually measuring peak expiratory flow rate, which we do continuously on our ventilators on patients that are in the critical care unit, we're actually measuring to see what the maximum amount of airflow is achieved when the patient breathes that air out. And normally, when we don't have ventilators, we can use a peak flow meter, and that will describe how well we are able to get rid of that air. Because sometimes in some of our patients that have tissue loss, such as with emphysema, they don't have very good expiratory flow rates, so they don't give off a lot of carbon dioxide, and they retain that. And that's why they have these acidotic states. So it's very important to be able to assess the function of the lungs and see if they're working well in that aspect. Now, if the patient presents with sputum, not only just a cough, but he's actually having sputum, you want to assess the sputum, because in many cases you'll be able to see if this is actually an infection that the patient has just by looking at the sputum. Most importantly, we want to assess to see if it's got any blood or pus in it. Pus will be highly indicative of some type of infection, and blood would probably be a case where you may have some irritation. Sometimes it could be in cause of some type of highly diseased states, such as with patients with tuberculosis, that they have this blood come up in their sputum. So very, very important that we make sure that we assess the sputum very well, because that's exactly what they've got inside the lungs. And for some reason or other, that's what they're excreting. So you want to note the color. You want to know the clarity of it. If it's a thick, tenacious type of sputum, or if it's really thin. And you want to see how much they're bringing out, and definitely check the timing and see how frequently they're bringing it up. So that actually completes the portion of the examination of the chest and lungs. I hope you enjoyed it. In the next video, we'll go ahead and start on our cardiovascular side of our assessment. We'll be assessing the heart in itself. So please tune in for that one, and thank you for watching.